So, hello everyone. This is video number 6, I believe, in this mini series, because video number 1 is an introduction to the CCS cases for step 3. So, I already did 4 of the free practice questions. Now I'll move on to take on the 5th practice question. Since these are free, I would recommend you taking them by yourself. And after that, come to this video and check it out. So I believe that first try it out. After that, if you have to commute, if you have to get on your car and you don't have much time for studying, you can see this video and it could actually let you know, okay, I could improve this, or this dude could have done this better, or whatever. So I guess it would be helpful, and it's something I would like seeing. So that's why I'm generating these non-edited videos. Okay, so first, how will you get to these practice questions? First, just go into your navigator and choose step 3 CCS practice question. Press enter and you'll get here, usmle.org. Okay, click on that. After that, right here, you'll see that you can prepare for your exam step 3 materials. Click on that. Go to sample test questions, click on that so you can see me a little better. Let's make this larger and let's go down to interactive testing experience. So the idea is that you practice this without reading what the question is about and how to answer it. That's the way you will actually get out of your comfort zone and grow. So okay, so as I said, these videos are non-edited, so you'll see the sneeze in the video. Okay, so we already did this one. This is the tutorial, and this is the introductory video where I walk you through this. Second question, first question is this one: 1, 2, 3, 4. Now we're going to question number 5. So it would be this one. I think, yeah, it's this one. Let's see what was the previous question to see if I already did it. Start case. Let's see what it says. And something I would recommend for the troubleshooting is that you do this in, let's see, 4-year-old boy. Yeah, this is the last one I took. So let's go back and do the last one. And I will do this better in Google Chrome, because doing it in Safari usually takes me out of the application. So let's try working on that. And without further ado, let's go into case number, which here it says case number 10. It's actually case number 5. So you'll probably see me go quicker through this. I know a little more how to play this game because I've already done 4 cases. Haven't done any more than that, so that's how you can see me progress, and probably this might help you out as well. So, okay, 18 minutes plus 2 in the end. Let's start the case and see what happens. So first window will be chief complaint. A 31-year-old woman is brought to the emergency department by her roommate because she has nausea and vomiting and now is drowsy and lethargic. She appears acutely ill and is lying down in a fetal position. So this patient is acutely ill and will be starting off in the emergency department. And yeah, it's very important that her neurological status isn't that good. So we could already be thinking of, okay, should this patient need an antagonist to certain medications or drugs? Could she maybe need intubation? So we'll see that shortly. Now we're moving on to the vital signs sheet. She is febrile. Remember that for USMLE purposes, 38.0 and above, which would be 100.4 degrees Fahrenheit, is fever. So she's febrile. She is tachycardic, and this is thready. So pulse is diminished. This is important. She's pretty weak. And she's also, for USMLE, 90/60 is like the definition for hypotension, but this is basically on the limit, so we could say she's hypotensive, she's tachypneic, and her body mass index is within the normal range. Okay, she's acutely ill, and we could say that she is probably in the border between instability and stability. I'd lean towards instability. I'd lean towards acting fast. Let's see the history of presenting illness. 31-year-old in the ED. Her roommate brought her to nausea and vomiting for 24 hours, so maybe she's volume depleted. She became drowsy and lethargic during the past hour. Okay, so this is the last presenting part. She did not eat anything yesterday because of nausea and vomiting, so she didn't eat and she was vomiting everything. Patient has type 1 diabetes. That is important to take into account, so she could maybe have an acute decompensation and usually takes insulin multiple times daily. Did she take it during the last 24 hours? We still don't know. She has not had, she hasn't had any insulin in the past 24 hours, okay? So probably she'll be hyperglycemic, then hypo. We'll see. Roommate is unaware of the patient having any abdominal pain, diarrhea, or fever, although the patient said she had some chills yesterday. Okay, so could she have an infection? Could she be septic? Maybe. The patient rarely drinks alcohol and uses no other medications or substances. So this is basically letting us know that this isn't going along the line of intoxication. Past medical history, other than diabetes, nothing else special. And we already know this. No, we don't know family history because she's drowsy and everything. She's divorced, no children, a Mexican, personal habits, smoked a half pack of cigarettes daily for 3 years, rarely drinks alcohol, doesn't use anything else, and she's a sales representative. Okay, so there we have everything. So first off, we have to check before the physical exam in this patient. Number one, well, we want a neurological exam. Yeah, let's go to the neurological exam. And we want to see her skin. We want general appearance. We have to act fast. Cardiovascular is important in her. Abdomen to see if she has pain. Lymph nodes if she's infected. Breast not important. Head, ear, nose, maybe she might have an infection. So let's check these out, and that's it. So let's press OK on that. Yeah, we know how much time it will take, and press OK. And also, I want to immediately check her blood glucose. I want an EKG, although she doesn't mention chest pain. It might be important, maybe not. Let's see. General appearance, well developed, thin, no apparent deformity, acutely ill. We know that. Skin is dry, poor turgor, no lesions, so she is volume depleted. We want to give her a saline immediately. Mucous membrane is dry. The rest of this head, ear, and nose normal. Chest and lung tachypneic, normal chest wall motion. Diaphragm and chest move normal, no abnormality. Okay, she doesn't have any lung infection. Tachycardic S1 and S2 normal, no murmur, rub, blah blah blah. Pulses are thready, no JVD. Blood pressure equal in both arms. Abdominal sounds are normal. Diffuse mild tenderness. Okay, this could be a diabetic ketoacidosis. And she's lethargic, disoriented. Findings on cranial nerve normal. Cerebellar function normal. Deep tendon reflexes normal, but she's lethargic. Okay, so this would be important to know her Glasgow Coma Scale. How is she functioning with pain? What's her stimulation results and all this, because we have to know if we have to intubate her. But since it's not that explicit, I'm not going to intubate her right now, so we'll give it a chance. We'll write the orders up first. I want saline, let's see, NaCl, let's see, IV, NaCl. Let's see what happens with that. We want a glucemia, glucose. Let's see what happens with that. We want a CBC. We want a BMP. We want arterial blood gases right now. Arterial. Don't think a chest x-ray might be necessary or an EKG. This is probably good to start off with. Urine, we don't lose anything. Urinalysis, if we can get it, and that's it. Let's go with that. IV normal saline, yeah, we want it intravenous, we want it continuous. Glucose, so this is where it's important to know how to play this game. So as you can see, random, so glucose serum random, yeah, but I want to see a micro method, the one that is immediate. So fast and random, that I believe that's not the best test for it, but we'll choose that one, and we'll also choose the one I'm looking for. CBC with differential, BMP, arterial blood gases, and she had abdominal pain, but let's start off with this, and doesn't need an ultrasound, for example, right now, and also want a glycemia micro method. That's where the language barrier is difficult, because I usually send this in Spanish. So yeah, confirm orders. Bedside glucose, not sure. Bedside glucose. Bedside glucose. Yeah, I guess that's it. So let's see what happens. We want to see next available test. Next available test. We want to see that glucose and everything. So 455, yeah, she's in the range of, it could be hyperosmolar, it could still be ketoacidosis. Remember that hyperosmolar is even higher, so it's like in the mid-range between those two. Let's see what else we have with the next available result. Let's move on. 7.1 pH, PCO2 is 20, PO2 is okay, bicarbonate is 6, oxygen saturation is 94. So she has metabolic alkalosis, no, metabolic acidosis, right? And she also has respiratory compensation, which is partial. That's why we are mainly acidotic. Okay, so we're not giving bicarbonate. That doesn't make any sense right now, and won't do harm, but it won't. Yeah, it's above 7.1. The studies don't say much about it. So how much time has simulated time has passed? 27 minutes, and real time, day one, we don't know yet. Okay, next available exam, or I want to see an interval. We already gave her all this. I want telemetry. We want to monitor her. It's important, telemetry. We want her still in the emergency department. We're stabilizing her. Let's see an interval follow-up. Not yet. Let's see her in. How is she doing? And with next available exam, cardiac attached and shows sinus tachycardia. Check output. Okay. Next available exam. We already know. We already know that. Okay, 20,000. Yeah. Erythrocyte, no anemia. Platelets are okay. MCV, all this is fine. Neutrophils, 15%, and she's also hypotensive. She could be infected, and the infection could be generating this problem. Normocytic, normochromic, leukocyte increase in number and normal in morphology. Platelets normal number, and let's get a blood culture. Let's culture everything. And yeah, and let's see an interval follow-up. Norepinephrine, not yet. Let's see how her vital signs are shortly. Sodium, potassium, 5.5. Okay, so we could give her potassium. It's I believe above 5.4 wasn't that good of an idea. So in general, they're usually depleted of potassium, but 5.5 doesn't seem maybe that necessary right now. Calcium 9.5, and she's very volume depleted, so that's why we're giving her. This is pre-renal, so she's depleted on that. And let's pH 4.8, 1000. Okay, clear, light yellow, negative, nitrite, positive, leukocyte esterase, positive. Okay, so she might be infected. Bacteria, yeah, she has a urinary tract infection decompensating this, and she's unstable. It's a complicated urinary tract infection. So let's see, before that, let's ask for cultures. Culture, blood or hemocult, I believe it is urine culture, and antibiotic sensitivity, maybe, not sure. And what else? Those are two good places to start. Hemocult, no, not that. That's not urine culture, not fungal. She doesn't have risk factors for all those others. No, not that. So blood culture. Yeah, right now. And we already gave IV fluids. Let's see how her interval is. Interval follow-up. And I'm not sure if I have to mark these. Let's see what happens if I just mark that. There has been no significant change. Okay, so let's see how her cardiovascular is. We want to see if she needs vasopressors, and after that antibiotics. We have to start her on antibiotics. Let's see abdomen again, and nothing else. Nice game, nice questions. Well, then we already know this, dry tachycardia. So there's been no changes. So let's give her an antibiotic. So order, we could give her, it's IV. We're not gonna give her oral anything. Could be Cipro, complicated, or a third generation cephalosporin, ceftriaxone. Let's go with that. IV, one-time bolus continues. We want that on several occasions. We also could help her out with some, we gave her fluids, but she's still with like hypotensive, and should we intubate her? She wasn't oriented to time, place, and all that. So let's review what has happened. Initial history and physical, neural, lethargic, disoriented, and there hasn't been any changes. Cerebellar, if she's disoriented to everything and she's lethargic, we could try to protect the airway, but I'm not that sure about that. Would this be, what are they trying to tell me? But in the interval history, there was no improvement. It's been already 45 minutes of elapsed time. We asked for all this. We started antibiotics. A central line, maybe, no. Let's protect the airway. Let's intubate her. Something is telling me we should better intubate her. So how can I intubate her? Yeah, I prefer that before her dying. And she's also tachycardic, norepinephrine initially. And let's continue. Let's see what happens. So that's it. With the next available result, let's see what happens. After discussion of potential benefits and risks, the patient, appropriate family members or guardian, the procedure is declined at this time. Okay, so that could have harmed. Let's continue. Patient is drowsy. What should I do? Should I stop it here? She's drowsy. I'm giving IV fluids. Potassium. KCl, IV. No. And I was going to change her to maybe the ICU, but no, she's still unstable. And okay, what else? Can't write any other orders. Yeah, exit case. Lab reports, we already saw them. She was very acidotic and everything, so that's it. So let's see what happened. Thank you for taking care of the patient. Okay, you're welcome. And block. And let's see what is the feedback. So let's see where we did harm, what we did good, bad. Okay. Let's see. Chief complaint: the differential diagnosis is broad and includes many causes of acutely altered mental status. However, the comprehensive history narrows the possible differential diagnosis, making uncontrolled diabetes very likely. Yeah, we know that. The patient has been experiencing nausea and vomiting for the past 24 hours and unable to eat. During the past hour, she has become drowsy and lethargic. She has a history of type 1 diabetes, for which she takes insulin multiple times. However, she has had no insulin in the past 24 hours. So initially, we didn't give her insulin. We just gave her sodium chloride, man. Oh man, that's a fail. Yeah, so we'll see it right here. The patient appears drowsy, lethargic, and acutely ill. Physical examination reveals elevated temperature, tachypnea, tachycardia, and hypotension. Cardiovascular exam shows thready central and peripheral pulses. Head shows head, ear, nose shows dry mucous membranes. Abdominal exam shows diffuse mild tenderness without guard and rebound. Neuro shows lethargic but oriented. Initially it said she was disoriented in place, time, and everything. But okay, maybe I ignored a new piece of information later on. Not sure. I have to review this. Taken together the history, and so that's why we didn't have to intubate her. And history and physical support the initial impression of complicated type 1 diabetes. In this particular patient, presenting with prolonged nausea, vomiting, lethargy, drowsiness, combined with the physical findings of fever, thready pulses, tachycardia, and diffuse abdominal tenderness, are highly suggestive of diabetic ketoacidosis due to infection and inadequate insulin. So we did that, we understood that, but we didn't give the insulin, which was the most important part. Well, maybe one could argue that hydration was more important, but insulin was definitely high up there. So, what would have the optimal approach been? Performing a targeted physical exam, including chest and lung. We did it. Cardiovascular, abdominal, neuro, and psych. That's exactly what we did. Order a serum glucose test using a glucometer. That's what we did with the bedside glucose. That's what we did. Urinalysis or complete blood count. We did that. Check for vital signs of infection. Yeah. Stabilize the patient with optimal IV fluids. We did that with saline. And treat the patient empirically with broad spectrum IV or intramuscular antibiotic. So I found out she had a urinary tract infection, so maybe that broad spectrum wouldn't be the case. So maybe ceftriaxone would be okay with the urinary tract infection, not sure. But we could say the patient was she had sepsis. So this wasn't only urinary tract infection localized, there were systemic symptoms. So maybe we could have broadened it a little, maybe. Once the serum glucose is obtained, start IV insulin is critical. So I definitely lost points in that. The patient's cardiovascular status should be monitored. That's why we chose telemetry, or by changing the location to the intensive care unit. Okay, I chose telemetry. Maybe I could have chosen repeat vital signs. Actually, I didn't know there's like a button to choose a repeat vitals, so that's very important. The diagnostic workup should also include arterial blood gases. We did ask for it. We asked for the bacterial blood culture. Asked for urine culture. We gave antibiotics. We did the urinalysis. We did the serum electrolytes to assess severity of dehydration. We asked for the BMP, continued monitoring of the patient's serum glucose, electrolytes, particularly potassium, and arterial blood pH after treatment is also important. So this is something I didn't do again. So I had to ask for this once again. So I believe that once you mark the lab work, you have to, instead of marking one time, you have to mark interval. I think that's the option. And definitely you want to see blood gases in a patient that is this critical at least every 4 hours initially. So that's important. Timing is critically important. An optimal approach would include completing the above diagnostic and management actions as quickly as possible during the first hour of simulated time. So there's where, when you receive the option of advance the clock, there's where you should stop the clock as soon as you have something useful to act upon. Okay, and additional tests that could be ordered that wouldn't change a thing. I didn't ask for any of these that wouldn't change a thing, but let's see, suboptimal management that could delay diagnosis or treatment. Okay, administering suboptimal IV fluids, yeah, we didn't do that. Initial treatment with subcutaneous insulin, we didn't do that. Suboptimal IV or IM antibiotics, I'm not sure if we did that incorrectly. I believe we did it correctly. We did it more directed. A third generation cephalosporin for urinary tract infection seems okay, but something is buzzing in my mind telling me you could have broadened this a little more. Not sure. What do you think? Let me know in the comment section below. And definitely I didn't give the patient the IV insulin. I just started sending other things. So instead of looking at the forest, I went and looked to the leaves on the tree. So I lost a moment the general picture and the most important thing, which was sodium chloride and the insulin. Examples of poor management. I could say I would actually give myself a bad grade in this case because of not giving the insulin that in and of itself should decrease points. Fail the case, not sure, but definitely decrease points. And that's it for this case. Tell me what you thought about it and leave your comments, likes, dislikes. That's case number 5. Next one, case number 6.